So we've had some conversations about frontline PARP inhibitors. There's no question that PARP inhibitors were first brought to the clinic in later lines of therapy, both in treatment and maintenance in recurrent disease. Michael, tell us about those indications and options.
Sure, and it's a fascinating story, which I won't go into great detail because it's fairly complex. But as you know, and this whole group knows, essentially the development of PARP inhibitors was almost abandoned.
Yeah.
And a lot of that happened at the time when Study 19 came across. It showed a wonderful PFS, did not show an OS, and at that point the FDA was still looking for OS differences.
Mm-hmm.
And that led to some discouragement among the companies, and there was a little respite there where there wasn't a lot of development. But to their credit, they got back on the ball, and the first approvals were in treatment. And we need to remember that there are treatment approvals. So the Bella Kaufman study, which is basically a basket study, showed a 34% response rate in patients who had recurrent disease, BRCA positive. And that led to the first approval for olaparib, followed very closely by Study 10 and Aurelia, Ariel 2, showing, and let me just define, the Study 42 was 3 lines or greater, the 4th line, if you will. Ariel 2 and Study 10 led to the approval for rucaparib in the treatment of BRCA positive ovarian cancer recurrent tumors, 2 lines or greater, and that wasn't by accident. These companies are smart. And then finally, the third indication we have for treatment is based on Quadra, which is a pretty heavily pretreated patient population, 3 lines or greater. Some of them, the average line I think was 5 lines in that study, but that's an HRD population for niraparib. So 3 indications for treatment. Now, while that was being developed, then we had all of the maintenance trials, which was really what opened the field up. The lead trial was Solo 2, which we've already talked about. Solo 1 is very similar to Solo 1. This is a BRCA positive patient population, platinum sensitive. They had to respond, PR, CR, randomized to olaparib versus placebo. Strongly positive trial. In fact, we just heard at the most recent meeting some of the long-term OS data from this study. After that, Nova and Ariel 3 right behind it presented their data. And that, again, broke the whole field open because Nova, much like Prima, used all comers and showed that basically niraparib in this randomized phase 3 trial showed a significant PFS prolongation. Ariel 3 is very similar to Nova, showing that rucaparib is also active. All 3 of those trials, randomized phase 3 trials, all published in the high impact journals, led to FDA approvals for the maintenance, the use of these PARP inhibitors in maintenance for recurrence after patients have responded to platinum. I have to emphasize that because the platinum response is used as a poor man's biomarker for PARP sensitivity.
But to your point, all had biomarker sort of indications.
Correct.
So olaparib, germline, rucaparib, germline somatic, niraparib, HRD, and then in the maintenance setting for recurrent, all had platinum responses. So that's very innovative. I'm going to sort of go a little out of order here, Leslie, for continuity, that at ASCO, there was overall survival advantage for Solo 2. Tell me, 12.9 months. So if you have a BRCA mutation, you get chemotherapy and then respond, and you get olaparib or placebo, you live 12.9 months longer. What does that mean to you?
Well, I mean, I think it's not going to change my decision to use the PARP. The PFS benefit magnitude was enough for me. And I think the OS endpoint is very difficult in ovarian cancer because of all the post-progression therapy that patients can receive. So OS is difficult to show. Now, if I remember that analysis correctly from ASCO, the OS benefit was not wholly statistically significant. It's almost not fair to say that because 213 really pushed, and we're talking about the upper bound of the confidence interval around the hazard ratio. And so 213 really pushed that almost to 1 as well. And, as Matt eloquently described, we do consider that to have an OS benefit. So to me, the OS is nice, but it's not. OS will happen when we start sequencing and using multiple active therapies in a row. And these trials aren't there yet. These are single maintenance and one-off trials.
But a very insightful comment. So, Michael, what do you think about that? That technically it wasn't statistically significant, but they said, we don't really care. It's good enough.
0.053. Close. Again, like many things are presented as good news and bad news. The bad news here is in the sense that I wasn't surprised. I don't know if anybody was that surprised. The PFS difference was huge. And I don't think it's going to change practice, but I will say it's very reassuring.
Yeah.
And, I would never quibble about that small difference. I think it's real and it's good. It's great.